luggage or bigger backpacks at the sides of the room, just to let you know. Great, that was very short notice. Now we start with the agenda for today. We're happy to have you here.
Thank you, Katrin. And also from my end, very warm welcome. We're delighted to see all of you here. So many people. It's a real pleasure to have you here. And also, Dr. Kippels, thank you so much for the appreciative words you found for the Global Health Hub. We are honored to have you here and can count on you as a supporter. Thank you very much. As Katrin said, we want to guide you through today's program because we have a full day of exciting and hopefully participatory methods prepared for you. And we will dive in with a panel discussion, and we will discuss what everyone in global health is discussing right now. What is happening with our global health ecosystem? Where are we heading? Where does it lead us also in Germany? Who are new emerging actors? Where is maybe a chance in everything that is happening right now? So this will be a panel discussion to start, and then we will stay on that topic since it's so important, and we will engage in a little experiment with you. After the panel discussion, you will have the chance to join the debate, to join the discussion, and discuss together with some experts that are in your teams, discuss along these lines where is maybe an opportunity in the challenge we are currently facing. So stay tuned and listen carefully during the first panel discussion because we will build on it. Before we break for lunch, you see here on the agenda that, no, you don't see it on this agenda. We will introduce you into the matchmaking tool that we offer. You received already some emails from us explaining something about a matchmaking tool. If these didn't make sense to you yet, no problem, they will after Katrin is done with her session. And then after lunch, to help us overcome our post-lunch fatigue, we have another exciting activity for you, and that will be a simulation exercise. So those of you who already know the Global Health Hub Germany know that we try to do things a little bit differently sometimes. We try to give different perspectives a chance, and we love perspective taking. So this is what we will do there. In a simulation exercise, we will all together step into the role of a community health worker who has to take a number of critical decisions while trying to operate in a conflict setting. In our last session on this side of the conference center, Mr. Kippels already mentioned it, we will talk about NCDs and mental health. Mental health has been overlooked for many years, a topic almost like a little bit unpopular, but we have to talk about it, and we didn't do it in last year's Global Health Talk neither, so this year we definitely want to do it, so we will build on what we did last year by focusing on mental health. Then, last but absolutely not least, we will invite you for a pre-launch of the Lancet One Health Commission report, which will be out very soon, but we in this room, we already have the chance today to get some insights into it, to maybe already get an idea where we are heading, and of course to listen to some engaging discussions about it. We will do that on the other side of the conference center. You already know it from the breakfast. Both because we think it's going to be late, we're going to be tired, so a change of scenery makes sense, but also because we then want to smoothly invite you to stay for our evening reception and maybe grab a glass of wine or water and drink with us on hopefully a successful day and a better global health. But now, enough talk about the future, enough talk about what's happening later. We are here now. Let's get started. And I believe Katrin has some nice ideas how to tune us in, right?
Thanks a lot. Thank you. Yes, all of you. We want to engage you. So we want to get your views in real time. To do that, we have a virtual voting tool. So please get out your phones now. I think most of you are used to that. It is called VoxR. You can see the QR code quite big behind me. So please scan it with your phones so that you can enter the link, enter the VoxR tool, and we can collect all of your, I see I'm still in front of it.
I feel like I'm standing in the way.
We can collect all of your ideas, all of your opinions through this tool. So to get you all started, we will ask the question we are always asking: which stakeholder group do you belong to?
I think maybe one thing, I think it's going to ask you if you have to enter a code. Oh. Click enter as a guest. There's not a code needed. And then maybe we can see some people nodding once they made it or shaking hands if you don't make it.
Yes, we can see that some people are already voting. So please.
No, it's not working.
Oh,
maybe try again. No, it's not working.
It's not working. Okay.
If you click enter as a guest, it doesn't. Okay. But what is this then?
I mean, some people are able to vote. We can see that some answers are coming in. I hope that you can ask your neighbor and get some help from the people who are able.
So it seems to work for a couple of people. It's seems not to work for a few others. So maybe we give you a few more seconds to try.
You still need the QR code again. Maybe we can show the QR code again. So please here, scan the QR code again if it's not working. I see some phones are up, so some people are still trying to get on the VoxArt
Let's
tool.
try it again.
Please try it again. I hope it works now. We are getting some more answers. We see from now that two groups are quite, many of you are here from academia and international organizations. So that's already quite a few. 73 people were able to engage on the tool. Do we get some more?
It's still not working? No.
Okay.
Okay, it's working for you. So, okay,
for 80, it's working, so we're still 82. We're getting some more people. That's great. We want to get all of you on board so that we're able to do that for the next sessions, because we're also forming some nice word clouds. I think questions like these, we are super able to do that without a voting tool, but it would be very nice to have some nice word clouds later on.
But so we see more and more people. 90,
91, yeah, 92.
Amazing. Okay, so it seems to work for more and more people. And yeah, international organizations, also many today.
Yes, also experts from academia, from government. We have 15% of you are from government, but also private sector is here, foundations, also some other stakeholder groups, think tanks. We have 2% of you are from youth. So that's already great. So I hope that a lot of you can now enter it, and we will try it again later. For the other sessions, but it's great if you're already here. And we will just see for the next question, we will go over to the second question to see if you're also able to form a word cloud. The next question would be, if a song would describe the current state of global health, what song title would it be? Please don't enter Highway to Hell. Please enter something nice, positive. You don't have to, but it would be nice. Enter some songs. We're not singing them. We just want to see together with you a nice word cloud. We are already getting some answers in. So I hope every one of you is on board, is able to enter something. Oh, we have actually some people. I think the word cloud will be shown in a minute. We have some people saying staying alive. Bridge over troubled water. That's also quite amazing. Money, money, money from ABBA. Temperatures from Paul. I like it. I will survive. Okay, it's very hard not to sing, but we give our best. Killing Me Softly. Okay, that's not the positive song we wanted to hear. Hello, darkness, my old friend. Okay, I see.
Help.
Help, yeah. Singing in the rain. Okay.
Run the World Girls. That actually fits to our global health talk today, because we have a lot of female power here today.
Definitely.
Wow, okay, I'm impressed. You're definitely very creative.
Move to
We
Berlin.
will survive. I like that one.
Move to Berlin, you get funds. Okay, what song is that? Have not heard of it. All right.
Perfect. Thank you so much. I like that. We will survive and staying alive are the biggest words here on the word cloud. So at least we somehow managed to end it on a positive note. Thank you very much for joining that game. We will do our best to contribute that global health stays alive today, and I guess all together. So thank you very much for joining us. But the song results, I think, also show that these are troubling times, challenging times for global health. We have to try to stay alive. We have to work on saving multilateralism. That's how it feels sometimes these days. And of course, as I said before, we also want to discuss the topic today because there's no way around what is happening out in the world, the disruptions we are facing in the global health world. So in our first panel discussion, we will discuss that. And I will hand over to my colleague Corinna, who will guide you through that session and then introduce the other speakers. Corinna, over to you.
Thank you very much. If I may ask Katharina and Angela, Mr. Paul Zubeil, to the stage. Please, yeah, if you sit here. We have, unfortunately, an apology from Mr. Sascha van Beek, who is held up in an overrunning committee meeting. And I am not sure. We have also an apology from Dr. Jean Kaseya from the Africa CDC, as he is currently at the AU summit and has been called to another meeting, plus having a sketchy internet connection. We are supposed to have somebody on his behalf online who will join in a minute. But I will perhaps do the introductions first. And
can you
as
hear
I
us?
said earlier, we face great challenges and change, and the global health architecture is undergoing profound transformation.
Can you hear us?
The political retreat of key actors from several global health institutions, most notably the United States, combined with tightening budgets, is accelerating the realization that the global health architecture may have been too fragmented to be effective in building resilient national health systems or in addressing global health emergencies. New geopolitical alliances, conflicts, and waning financial commitments are reshaping multilateral cooperation as we know it and as we speak. These disruptions coincide also with significant changes within Germany itself. A new government, shifting political majorities, and thereby having to find or argue the rationale for supporting global health, and increasing pressure on public finances are forcing a fundamental rethink of Germany's global health engagement. I'm very happy to have some very distinguished guests with me this morning to discuss with you how these changes are affecting their organizations and constituencies. What strategies do they apply to navigate them? And what should the new global health architecture look like to allow for more effective and efficient collaboration? So on my far right, I have with me Angela Bähr, who has been the Director of International Projects and Programs
Now I can hear you.
The German Foundation for World Population,
I can hear you now.
DSW. And since 2021, she has also been the organization's Deputy Managing Director. More recently, she became DSW's Chief Program Officer, holding responsibility of the organization's operations in East Africa.
The room?
Since 2021, Angela Bähr has served also as a member of the extended board of FENRO, the German umbrella organization of development and humanitarian NGOs. To my right directly is Dr. Catharina Boehme. Most of you will know her as well, is a global health. Catharina has been a global health executive with over 20 years of experience at the intersection of strategy, policy, and innovation. She currently serves as Senior Advisor to the Director General of the World Health
Take your
Organization.
speaker offline.
As
Not turned on.
WHO's Assistant Director General for External Relations and Governance, Dr. Boehme until
der kann
recently
uns nicht
led
hören,
corporate
seine Speaker sind
communications,
wahrscheinlich ausgeschaltet.
partnerships, resource
Also ich höre ihn, aber
mobilization,
der kann was
including
sagen. Und
the
so.
much famed
Can you hear
WHO
us?
investment round
Yes, I
and the
can hear.
work of the governing
You can
boards
hear.
that
Perfect.
set the global health
So,
direction.
Can you also hear?
To my left here on the panel is
Hello,
Paul
can you hear me
Zubeil,
now?
who is the Deputy
Yes, I can
Director
hear you.
General for European
Wonderful,
and International
perfect. We're
Health
just
Politics
finishing
at
the
the
introductions
German
and then we
Federal
will
Ministry of
show you
Health,
on the big
where
screen
he
and then we
leads
will ask you to briefly
Germany's
introduce
engagement
yourselves,
in
okay
both
for you.
EU health politics and multilateral
Thank you.
health
Wonderful.
cooperation.
So just
He
bear with
has
us a
over
few more
2
moments and
decades
then we
of
will hand over to
experience
you.
in international public service,
That's great.
including
Great,
senior
thank you so
roles
much,
at the
Dr.
United
Ngashi.
Nations.
Really, really happy to
As
have
Germany's representative in the
Thank you.
high-level panel
you.
of
Happy
UNAIDS,
to
he
be-
contributes to forward-looking discussions on the institutional future of the joint program and the evolving dynamics of multilateral cooperation. And now let me have a look whether we have Dr. Kaseya's representative with us online. Dr. Ngashi Ngongo, Principal Advisor to the Director General of the Africa Centers for Disease Control, is hopefully going to join us. I'll give it 1 minute before we start so that Dr. Ngashi can follow the discussion. Anyway, a very warm welcome to all the panelists. Dr. Ngashi Ngongo, welcome to our panel on shifting powers and global health. Thank you for jumping in at short notice to discuss with members of the Global Health Hub Germany on the direction these discussions are taking. Leonie, if you could ask for Dr. Ngashi to be put on this screen as well, that would be greatly appreciated. Thank you. Then we can interact more freely. Right. I would like to start with you, Catharina. With WHO at the heart of the global health architecture, can you please run us through the challenges that architecture as well as health financing are currently facing?
Thank you so Thank you so much, Corinna. And, first of all, very, very pleased to be here and part of the Global Health Talks. I look at you and I see many friends in the room, many great technical partners, many thought leaders and thinkers, and that's what we need, right? We have to find solutions together over the next coming months. And so very happy to be part of this. Perhaps just 3 points from my side to kick us off. The first, just to remind us, we're in a real global health financing crisis. The emphasis on crisis. This is not just a decline, this is a shock. The United States alone is planning to cut almost 60% of their ODA by 2026. The OECD projects an almost 60 billion decline in ODA over the next 2 years. So this is not just a US cut, it's a cut driven by many countries. And we as WHO see already now very severe disruptions in healthcare delivery in over 70 countries. We see on a day-to-day basis more health clinics closing. We see now significant stock outs in terms of supplies, medicines, testing, access to condoms, etc. So the situation worsens. I think we'll hear from the Africa CDC, though, that countries want to very much move to domestic self-reliance. We hear a lot of discussions in terms of trade for aid, in terms of partnership instead of support. But for many countries, the transition is too abrupt, and it's not possible for them to, to step up domestic funding so rapidly. So patients are paying the price, and health security is clearly paying the price. And, I still think as part of this debate, we have to also think through what can we do very acutely, what fund can we set up to help in this very acute crisis situation. So now to the architecture. On the architecture, I want to say, the system as it was built over the last 2 decades, a system of vertical players by and large, has delivered, right? And we mustn't forget this. I want to really start with a positive point because we've seen massive progress when we think of child mortality, when we think of maternal mortality, HIV treatment scale up, malaria incidence reduction, etc. So there was clear progress. However, while we've saved millions of lives, what we see now is that this system is no longer fit for the purpose, is no longer fit for purpose for this new era we will see in global health. As you've said, it's a very fragmented system. We count still 12 product development partnerships out there. We have hundreds of NGO players, still a lot oriented by single diseases, disease by disease, vertically oriented. Whereas what is shifting is the disease landscapes. You will speak a lot about NCDs this afternoon, mental health, which now even in low-income countries are leading causes of death. The demographics are shifting. We're not prepared for chronic care, aging. And of course, the science is shifting and much more complex. So we need horizontal integrated approaches. We need consolidation, and absolutely everything should be on the table, from sunsetting to mergers, etc. And my last point is, yes, there is momentum, and we need Germany and the German actors very much at the table. The UN 80 reform has started. Many of you will have seen after, from my perspective, a very successful Gavi replenishment, which actually deserves an applause, I feel. Also, with the help of Germany, many of you may have seen the Gavi Leap announcement. There's a lot of thinking on new operating models between Gavi and the Global Fund. I just come together with Jean Kaseya from a Wilton Park dialogue, where a lot of creative, innovative thinking went into how can we reshape the global health architecture. So I do believe that with the right reforms, we can create a system that's fit for the future, that is able to learn on the spot, to adjust on the spot, and acts locally while working and continue to work globally.
Thanks very much, Catharina, for setting the scene of where we stand currently on global health. Angela, you represent civil society on our panel and also work with partners in the field. From your experience, how do the changes impact healthcare delivery on the ground, and what adjustments do civil society organizations have to make as a result of shrinking financial spaces?
Thank you so much.
Good morning to everybody. Thank you so much, Corinna, for the nice introduction, and also thank you for having me here. I'm really happy to be at this Global Health Talk today and share with my dear colleagues here on the panel. And Catharina sets the scene in a very good manner. I really can't do it better, to be honest. But yes, I can give you the perspective of civil society. Let me give you a background first. USAID, or only USAID financial resources financed over years around 40% of development cooperation and humanitarian aid in civil society sector. That also means what kind of consequences this shock, and I totally agree with Catharina here, this shock is causing in the global south and also especially in the United States. We have to say it. When we have made in FANRO a request of the consequences to German NGOs. That's at the moment, it's not directly so much, to be honest, not directly, but indirectly, it's different. And I was thinking when I was sitting here and talking about global health here in a wonderful room in Berlin. 2 weeks ago, I was still in Tanzania in district health systems. I was also in Uganda, and I can notice what is happening on the ground. So yes, also the NGOs, the Global South NGOs, they are really saying, even if they are in a harsh, but really harsh conflict, existing conflict, because they have to fight for the annual budget, they lost the financial budgets immediately, to be honest. So they are thinking, they are saying, okay, in our countries, we need to work together and to build up a system with our government which is working. That is true. But on the other side, you have the high population there and the really young population, and you have the real problems on the ground. For example, clinics really are closing. Mother-to-child care does not work. They are sitting a lot, but really a lot of young pregnant women in district health clinics which don't have or which only have basic, but really basic conditions also for birth control, for example. So that is really incredible. And it will tackle at the moment the most vulnerables. Means the last mile, which is normally reached really by community health workers, for example, or also by a lot of NGOs. The last mile is the first one which will not have access to services, neither access to basic health services. We are looking at, I'm really the same happy about the Gavi treatment very much. And I can also state that some more campaigns of Gavi and now projects can start again. For example, in northern Uganda, I really know, they just started, they signed the contract with the NGOs. They are going to really to give the infections, not the infections, the injections to the people, etc. So that is really very nice. But having a look on HIV/AIDS and SRHR, which is the most affected topic also by USAID funding and the PEPFAR programs, it is a real disaster. Teenage pregnancy will raise up. Normally, there is a big campaign still on contraceptives, on modern contraceptives, which is good, and on the dual protection. But now, if the whole HIV/AIDS programs and PEPFAR will not work, and it looks like that it not will work, or it will work until September, and then no treatment, neither the treatment will be given to the HIV/AIDS affected persons, then we need to be aware that in between 3 to 6 months, we really will have facts of diseases, very clear. It is very clear what will happen again. And that the country itself, for example, but also us, we need to discuss about the repercussions which will have, especially HIV/AIDS in East Africa again. So I really have to say this. NGOs, what they are doing, sorry to say this, NGOs for sure, we need to also to review how we are working. That's definitely true. We need to diversify our donors. I also think so that it's definitely needed to have more public-private partnerships. For example, it's needed to build up in countries where it is possible, also something like a sponsoring society, really. So there are a lot of ideas, definitely, but all this needs time. And, yeah.
Thank you, Angela. The last mile is the first mile that will lose the access to basic health care. Paul Zubeil, to my left, in his opening statement today, the new Parliamentary State Secretary, Dr. Georg Kippels, emphasized Germany's readiness to help shape a global health landscape that is more sustainable and fit for purpose, including for the last mile. What would you say can Germany do in times in which its federal budget is also strained to build an architecture that is fit for purpose? Thank you.
Thank you very much. And first of all, thank you for inviting us to the Global Health Talk. I think it comes in a very timely frame. Now, let me offer maybe three reflections. At first, I believe, and let me start on a positive note. I think we should remember that Germany remains one of the largest contributors to global health, but shaping a new era of global health obviously goes beyond financing, it goes beyond budget. So what this momentum, in my view, calls for is really a value-driven and a strategic leadership that we need. Germany has been a long-standing partner, a very reliable partner, bilaterally, regionally, but also globally, and that will not change. The support of Germany will not change, even if the landscape is modified significantly. Now, secondly, what really drives me and it gives me a lot of food for thought is that we always talk about the global health landscape. It's fragmented, and we only talk about the institutional part. Let me explain this. We also only talk who does what, who exists, and who does what best. But what we need to look at, in my view, is that we also look at the donor side, because that's hugely fragmented as well. So what we have right now, we have a shift from the many and the shift to the few. And that we need to reverse that trend. And I'm trying to get my head around it. How do we do this? And my answer, my reflection on that is that we need to actually foster and intensify the bilateral exchange. We need to talk to member states and to other partners and build strategic coalitions and partnerships. So how can we get them back? Where do we intersect? Where do we have common ground? So instead of regretting withdrawals and talking about shocks and what all that means, yes, it's important, but we also need to be forward-looking and say, how can we actually rebuild that trust and actually get the donor side back on track, that the global health and the architecture is solidly financed. Thirdly, we need to ask the tough questions, and Catharina has mentioned it already. We will need to talk about questions and initiatives like sunsetting, like right-sizing, like mergers. All these are questions that we need to put on the table if we are serious about reform. Reform is never about disruption, it's about purpose. And as the government of Germany, we can actually help anchor that purpose and drive it forward. But we need to ask these questions that we have built a more efficient and a more resilient health system going forward in the next years, in the coming months. Thank you.
Thank you. Thank you, Paul Zubeil. So some of the reform approaches, Dr. Ngashi Ngongo, are already on the table. The Director General of the CDC is a strong or a vocal advocate for African countries and their regional organizations also taking more responsibility in the governance and financing of health. Overall, we have already heard, though, that funding volumes are significantly declining. Where can you already observe new approaches in terms of organizational reorganization and financing taking shape in Africa? Are you still on mute, Dr. Ngashi?
Yes, can you hear me now?
Yes, we can hear you. Thank you.
Yes, let me first start by thanking you for inviting Africa CDC to be part of this very important discussion on a topic that is so current and really at the heart of what is happening on our continent right now. And also present apologies from the Director General, who is currently in Malabo at a high-level meeting of the African Union with head of state. I think that's the reason why he asked me at the last minute to come and step in for him. Yeah, I think just first of all to confirm that the funding cut, the crisis is very well felt in Africa. But it is not only this year. I think what we are trying to say that when we look at the trend from 2021 to 2025, there was already that declining trend, of ODA to Africa, about 70% reduction in ODA already. I think what has happened now is has just worsened already something that was happening. We are doing some work with UNICEF right now. We've almost finalized that work to try and understand what's the magnitude of the funding loss on the continent, and what are the programs and services that are the most affected. I think we've also done that to understand exactly in terms of the mitigation measures, where we know exactly where we can direct our interventions. I think one observation that I would like to share here is that, we noticed with the data that is coming up that about 75% of all funding coming for health in particular bypasses national health system. Now, just to say that, this whole fragmentation of global health initiative, has also had another impact on really not supporting the strengthening of national health system so much. We've also maintained that culture of, bypassing because they are weak, but not investing, but still observing that they remain weak, and therefore we don't need to invest in them. Now, when it comes to now your question about the architecture and some of the things that we say are critical at this point, it's 3 points. One is that when the global health initiatives were started 20 years ago, I think some of the key regional players like Africa CDC did not exist at the time. I think we are at a different time in history. We have these growing regional organizations. I think as we look at the global architecture, is also the recognition of these growing regional organizations, and also our commitment to ensure that they become like our frontline support to the member state, and then also seeing to what extent this global initiative can then work through them to reach the member states. That means, as I was happy to hear that reassurance that Germany, as one of the key supporters, is not going in the short term to reduce its contribution. I think one of the priorities is the support for strengthening regional organizations. That is critical. And then the second thing, on the financing itself, we have the Lusaka agenda that all of you are aware of. Africa CDC is leading that on the continent. And at the AU Summit of 2024, the head of state recommended that Africa CDC establishes an accountability framework that allows us to see exactly how we're bringing the global health initiatives together on the African continent to reduce the fragmentation. Just to quote one of the ministers that reported to us that in his country, every year they develop 32 plans, 32 required by different donors and different partners, and all of them do have different oversight mechanism. Now you see that those are things that as we have now this crisis, we need to take advantage. The reforms that were spoken about. How do we also ensure that we bring those global initiatives together into one plan, one oversight mechanism, one monitoring framework? Underlying all that is the strengthening of national systems to be able to deliver, on the national priorities. And the third point I wanted to make is that Africa CDC has laid already effort on the continent to develop the health financing strategy of Africa that was really fully supported by the head of state and all ministers of health on the continent. That has got three pillars. One is the strengthening of domestic resources. You are aware of the event that Africa CDC organized with President Kagame of Rwanda, who was identified as the champion on domestic financing. Just bringing the head of state to now think in the context of the current crisis. We had the Abuja commitment 20 years ago. Only 3 countries have achieved that: Rwanda itself, Botswana, and Cabo Verde. And how do we then use a champion from a country that has achieved it to support other members also to follow suit and do the same? That is one of the pillars of the Africa CDC health financing strategy on the continent. The second is on domestic resources. We acknowledge that the fiscal space of some of these member states is not enough. Even if they reach 15%, the question of 15% of how much? I think for some of the countries where the budget are already small, even the 15% won't be able to generate enough resources for investment. That's why we are really pushing this domestic innovative financing. We've already started interacting with some of the big companies on the continent, like Ethiopian Airlines and so on, that are very much willing really to support this and generate additional resources. And the last pillar, the third pillar, is on blended finance, where we see that when we very much understand that the time for donations is kind of over, but we would like to also engage the private sector in a business kind of way that they can come invest in certain sectors in Africa, like in the local manufacturing, in the digitalization of primary healthcare, and so on, that they can get returns on investment, but while at the same time also responding to the critical needs of the continent. And the final idea to say that what our financing strategy is also pushing is the strengthening of the governance and the efficiencies to ensure that the corruption and all those things, all those evils that have also played in the past are addressed. I think that's how Africa CDC is approaching this whole health financing crisis on those 3 grounds that we hope will be able to contribute to alleviating really the crisis on the continent. Over to you.
Thank you very much, Dr. Ngongo. We have already heard a lot about the challenges that the African continent faces. We've heard that some governments have to draw up to 32 different annual plans. Dr. Ngongo has said that 75% of funding for global health bypasses national health systems, but that on the other hand, there's also a great commitment from African countries to invest more through domestic resource mobilization. So, Angela, from a civil society perspective, how would you say can Germany support these efforts? How would we negotiate that at a political level? And would that then represent a continued commitment to of Germany's commitment to its international partners?
Very difficult question now, but let me say, even if it looks like that there is a negative decision, but as a German civil society, we would like to say that the subcommittee of global health in the parliament would be more than important in such an important or in such a critical moment, because that is a space where experts, parliamentarians, etc., really can discuss, and where global health as a topic, besides for sure the responsible ministries as the BMG and the BMZ, they are there, but could be discussed at a length, first of all. Secondly, as I talked about the civil society in the Global South, you will be sure that I'm saying that's not the moment to cut more of the financial resources of the NGOs working in development politics in the Global South and supporting extremely our brother, sister NGOs in South in the health sector. And that is happening because there is a really extreme cut in the financial guidelines of private donors in the budget for 25 and 26. So that means that has direct repercussions also on German NGOs and on their capacity to really to work together with civil society in the South. But coming back to the global health strategy, that is extremely important. Dr. Kippels was mentioning the BMG's global health strategy. We are definitely going to support the further reviewing of this strategy. And having a look on the agenda setting, it's extremely important to be a reliable partner in this moment, really a reliable partner to the multilateral organizations, but also to some of our bilateral partner countries who are interested in really working in the health sector and who are interested in strengthening financial health systems, etc. Because to avoid, thank you very much, Dr. Ngashi, to avoid the out-of-pocket spending, what is happening in, for example, in sub-Saharan Africa, but also in other countries, it needs really a good health insurance, for example. And a lot of the countries, they need technical support, only the technical support in introducing this one. But what is happening in a lot of countries at the same time, coming back from East Africa, they are really shrinking spaces at the moment, even for civil society. Yesterday, I heard that Ethiopia is one of our main partner countries. Yes, I know, sorry. But will have a new NGO law and is restricting even more the spaces really for NGOs in Ethiopia. Only to let me say this, you feel that I had a lot more to say. Only one word. In this crisis of HIV/AIDS, I already sent it, the global fund replenishment. It's extremely important.
Thank you. Thank you, Angela. Katharina, the WHO is also on the ground in many of the countries, also in Africa. How is the WHO responding to the challenges there and globally? What are some of the approaches for internal reform and suggestions for reforming the global health architecture? We've heard some of the direction, but perhaps you have some more concrete examples. And where do you see also resistance to these suggestions?
That's a long question, but I hope we'll have time for discussion. So let me be brief. So first of all, how is WHO responding to what is for us really an existential crisis? We are under a huge pressure to do more with much less money. And where we don't want to end up is with salami slicing, right? So the big risk is that we still do everything, but we do everything with less money. And that's what we wanted to avoid as WHO. That's why we've gone into a prioritization process, very much focusing back on our core mandates, protecting what we call norms and standard setting, our coordination convening role, our data role, and our pandemic preparedness and response and health emergency core function. We're really focusing on what only we as WHO can do and can contribute, and will rely much more going forward on you as our partners to do the rest. We've decided we are cutting headquarters much more than the others, the regions and the country offices. So we're cutting in headquarters 40% of our staff, in regions 15 to 20%. We're closing country offices. We'll close our first country offices within the coming months. But where we don't close, we try to preserve our country presence, because that's where we see the future and we need to be on the ground, right? So that has been Dr. Tedros' priority and will continue to be, I think, also his legacy when he leaves in 2 years. I think organizations in crisis are at risk to be inward looking. And that's what we don't want to be. So we're very much engaged in all the reform processes, UN80, the humanitarian reform. You know, as you said, Dr. Ngongo, very much building on the Lusaka agenda, which we as WHO firmly believe in and are very much pushing forward with. Where do I see the resistors, right? So perhaps, first of all, this has to be building from the countries up, right? Exactly as you said, where still we see processes are too complex, we have too many mechanisms, countries spend more time on grant reporting than on serving their patients, basically. And I still don't see the IFIs, the multilateral development banks, the global health players come together to really help countries. We work closely with the World Bank as WHO on the ground to help countries facilitate. And we see a huge role for regional players, namely Africa CDC. But typical resistors, right? In 20 years in global health, I have seen one merger. It's not easy to merge entities. Institutions don't give up mandates or visibility voluntarily, generally. There's always at least one donor who loves one entity, right? So generally what I've seen over the years is that it's really hard to kill entities. They rather limp alone and continue to limp alone in a fragmented world. And I think that's what we have to overcome. Donors don't like pooled funding. We live in a world where trends are actually going back to bilateral funding. You know, I think this multilateral pooled funding, preserving that, making it easier for countries there's still a long way to go. And then, you know, perhaps overall, in general, in global health, we've been better at talking than at executing. And we do not have very strong governance at the moment. So what do we need to do to overcome this? You know, we're discussing setting up reform tracking platform, basically, so that we can actually transparently track progress on the reform side. We're discussing setting up a standing mechanism that is neutral, that can guide us and help us on the way forward. And, you know, as I said before, we very, very much need Germany to help us align funding, align the actors, align the mandates where we see a lot of duplications, and all this with country priorities in mind, and country priorities really guiding this reform progress. Thank you.
Thank you very much. I think you've basically just laid out a 10-year work program for all of us. Dr. Ngongo, you already mentioned earlier that African countries are ready to take more ownership, to take over more ownership. And what we see now is quite a number of processes whereby countries come together to discuss what the architecture should look like. And I wanted to ask you what some of the criteria would be with which you would evaluate potential changes to institutional divisions of labor in the global health architecture and new unions or mergers. You know, what are some of the criteria that the new architecture would have to comply with to be in Africa's interest?
Yes, thank you very much for that very interesting question. I think the most important criteria that you like to see on the global health architecture or players is first of all alignment with national priorities. I think that is one. So that as we come in, I think we need to align behind national strategic plans of countries rather than just starting new initiatives that also set up vertical systems. And secondly is also the integration, into national health system which is critical, so that we can then start moving away from the multiple. See, every partner brings its own oversight system. Global Fund has got one, Gavi has got one, GFF has got one. I think starting now to move away from that, go toward integration, into national health systems. And then thirdly is also, we like to see the strengthening of national system as an intentional focus of all global initiatives. Because if we leave them weak, they have been weak since independence for 60 years. We continue bypassing them because they are weak. But if we do not invest in them also to get the needed capacity and standard of performance, when are we then getting to get those systems that are integrated that we are looking for? And the last one, very important also even for Germany, is also the support to the strengthening of the regional organization capacity. I think because that is the kind of long-term sustainability strategies, that if we get national systems that are strong and integrated, we get regional organizations that are strong and then can play the role that we expect of them. I think in the long run, we can then sustain the investment of any partner of the caliber of Germany, for example. Thank you very much.
Thank you very much. And before I now open to you, open the floor for questions and comments, one last question to Paul Zubeil. Hearing all this, how will the Ministry of Health support the process, or the German government, maybe I should say as well, under the strategy for global health, support the process of reforming the global health architecture?
Yes, thank you. Let me be quite brief and also again give you three aspects on top of my mind. First, on WHO, and Catharina had already said it, Germany has been and will stay a very vocal supporter of the WHO prioritization process. It's made it very, very clear to WHO that it must focus on its core mandate, and that's also what's happening. So it's already full in progress data, health security, coordination, norm setting, etc., PP. So that is good. For us, the key is really that is efficiency. So that WHO comes out of this reform process with a really genuine new structure, stronger than it was before. As Germany, we've always supported WHO, and we want very strong WHO because we think it's really needed, and nobody else can do the job that WHO can do. But what we must not have is just a reshuffling of positions or just a simple downsizing. It really needs to think outside the box, look at new perspectives, new ideas, and also moving out of the comfort zone. And at least to my impression, that's on a good way. And WHO is in the midst of doing that. Now, secondly, on UNAIDS, how do we support reform? As Germany, we've been on the high-level panel on the restructuring of the joint program. The result of that is that the UNAIDS will have a leaner secretariat. They've done a good job in actually moving staff and relocate its workforce to lower cost settings. But also, as Germany, we help to protect what actually works. And one thing that is particularly very important for me is that we actually keep civil society in the spectrum as well, and that is actually ensured through the governance model of UNAIDS. So we didn't touch that, we didn't change that. We just tried to make it leaner and more efficient, and they now have a model that I think actually, even with this decreased budget, can still work. So, and that's also what the WHO has referred to a little bit. We don't want to limp around and just do with less money everything what we've done before, but just not in the same quality as we did before. So I think that's very important that we keep, that we support the reform process in that way, that it's agile and that we still do not compromise on quality. Now, on the third point is, how do we support reform? We're creating spaces for dialogue. You know that we have the WHS with more sessions than ever before at this year's World Health Summit. And of course, we'll talk reform, we'll talk changes in global health architecture. So we are opening the space there for dialogue. At the same time, we also at the midterm review of the Germany's global health strategy. Also there, we will look what works and what needs to be reevaluated, and I won't give any preview of that right now, but there's a lot to be changed. So in a nutshell, when I just spoke about all this, so we're not only demanding reform, but through our engagement at WHO, at UNAIDS, at other formats and dialogues, we really try to help design it together with all of you as well. Thank you.
Thank you very much. We have the tasks in front of you and in front of you and us. And I would now like to invite you to ask questions to the panelists or to comment, share ideas that you might have, or engagements in different international processes that you may be involved in. So who?
Thank you very much, Corinna. I'm Sharbani Chakraborty from the Center for Global Health at Technical University Munich. And it's a really important discussion that we are having today. And one of the questions I have is about fiscal space in sub-Saharan Africa, because according to the IMF, 58% of sub-Saharan African countries are already in debt distress. So when we talk about, for example, Germany has been very innovative working with the Global Fund around the debt to health swaps. But going forward, where we see NCDs, mental health, and other issues coming up, are there any opportunities to think about this innovative mechanism to support integrated health services delivery and financing? Thank you.
Thank you. We have a comment from Ms. Rüdiger Vorwerk in the first row, then Sonja Gregert after that.
Thank you so much. My name is Tanja Vorwerk. I'm working in the BMZ, and it's less it's more a question, and this is addressed to Catharina and Paul. So the big elephant in the room is the global health architecture, and you have already spelled out some criteria for it, but I would be interested, what are the main criteria you are seeing which should be at the end be part of the new picture?
Sonja Gregert had raised her hand.
Thank you very much. My name is Sonja Gregert. I'm from Venlo, and I would like to ask a similar question as the colleague over there regarding financing. We already heard a lot of countries are in debt distress, and I'm wondering how our discussion on financing global health and health systems locally relates to more structural related issues like a sovereign debt mechanism or the UN Tax Convention, and how we relate to these discussions and try to mobilize funds through a better tax system or debt cancellations. Another issue I would like to ask is especially to Mr. Ngongo, how you are approaching public-private partnerships and blended finance, because in last week's conference on financing for development, there was a strong push for blended finance instruments, but also there was criticism that these have not been working in the past. So how are you planning to ensure that they deliver what they are supposed to do? Thank you very much.
Beate Kampmann, and then you will have to be the last questioner after that. Thank you.
Thank you, Beate Kampmann, Director of the Center for Global Health here at the Charité in Berlin. Thanks very much for this very engaging discussion. I haven't heard much about South-South partnerships, new partners that might be playing an increasing role in the architecture that we're talking about. And the other thing, particularly from Herrn Zubeil, the role of Germany within the European plan for the collaborations in this new architecture. Thank you.
Good to see that only women are asking the questions. Very good. Thank you so much. My name is Sonia Diaz. I am from Colombia, working in Freiburg University. And I like very much what Catharina said, that perhaps we are very good in talking rather than implementing. I was working at the Global Fund in 2003, and we were talking a lot about the Paris Declaration and the principles that we saw at that time, the 5 principles, until now they are exactly the same. And so I think that perhaps this crisis is a good opportunity to reflect on what we are doing. And my question specifically is, what are these new criteria to prioritize the activities, the countries, and so on? Because until now, coming from Latin America, I can see that the money goes mainly to Africa and also to specific activities. Perhaps this is a good time to rethink that maybe the money goes to more developed countries, that maybe this push can give a little more impact. Some questions to reflect. Thank you.
Thank you very much to you all. I would perhaps hand the question of the role of Germany in the EU discussions to you, Mr. Zubeil, and if you have any comments on new financing instruments, please also feel welcome to share them.
Yeah, thank you. Maybe first of all on the EU role in the whole global health architecture. So the European Commission has put forward a global health strategy, and of course we are aligning those. And what we are facing right now is that a lot of the European states have their own global health strategies. I was asking my questions, do we map those? Do we see actually where we have common interests or where we have intersections? How can we actually leverage on those? I mean, if we look at the global health strategies, for instance, for France, we have our own. I see a lot of common interests, for instance, also with the Netherlands. So there's a lot ongoing. But at the same time, it's clear that there will be no financing instruments. In terms of crisis, it always almost reflects, so, oh, we need a new instrument and that needs to be resourced and financed. So I don't see this, frankly, coming in this environment we are currently in. So what we rather need to look at in the global health architecture is where can we look for consolidation? If you look at duplication efforts, if you look in inefficiencies or in a number of institutions or organizations that are doing the same things, can't we pool those? We really need to see where the savings are, and I think there are a lot around there, and that will be the task of all of us to actually map the landscape and to see where we can get the efficiencies. But at this point in time, very frankly, very honestly, there won't be more funds.
Thank you. I would like to use this round as the closing round as well. So if you would have any more general comments as well, then I would ask you to.
Yeah. I really think that let's not design new blueprints. Let's really look at what we have and make bold choices. I think what we need is clear mandates, we need clear coordination, and we need also shared accountability by all. But of course, we need to talk about partnerships, and Bähr mentioned it. We need to talk about North and South. We need to talk about donors and implementers, and we need to also talk about civil society. I think that sums it up, that we can actually put our heads together and talk about the mandate, the coordination, and the partnerships part.
Thank you. And I will ask you, Dr. Ngongo, hand over the questions on responding to the criticism of blended finance, and also perhaps the question on South-South partnerships, what you can share with us in that regard. and to also make a brief closing statement before we continue here on the panel. Thank you.
Yes, thank you very much. Now, on the question of blended finance and how to ensure that this time they do deliver, I think some of the things we've considered, I would like just to mention two. One is that we have identified the priority areas that matter for Africa and contribute to the public health agenda. As I mentioned, the local manufacturing, the digitalization of primary health care. I think that is the first thing that we've done. And then secondly, we've also agreed, just building on the head of state recommendation to Africa CDC on the Lusaka agenda, that it makes sense to develop an accountability framework that defines the role and the expectation from each of the key players, in this agreement. I think those are the two things that we feel that will help us improve the way that these finance development initiatives, will be playing their role on the African continent. On the question of the South-South partnership, I think a lot of positive things that are happening. We have a bilateral agreement. For example, Africa CDC has got an agreement with PAHO now, where we are sharing experiences, I think, in these specific areas. I think there was a team from Africa CDC that visited PAHO, and we also had a team from Latin America that came to Africa CDC. I think we're also trying to learn our own lessons on things that matter for us and some of the experiences that also can benefit each other. And I just wanted to make a comment also on the question about the fiscal space. I think what we see from where we stand is that with the whole idea of prioritizing primary health system is also bearing in mind that we need to go where the cost of our services will be the most affordable. I think that's the reason why we are going back to really bidding on the Astana the declaration to strengthen primary health care. But at the same time, also recognizing that the member states as they are now with all those constraints won't be able to put that much. That's the reason why we are pushing for the innovative financing. And in addition to that, we've also reflected some of the strategies that can help us also build some efficiencies like the digitalization. For example, we'll be pushing things like telemedicine, which is much more affordable to provide high quality care in places where you don't have doctors, rather than aiming to recruit them in those places where the infrastructure does not allow. But then to conclude, just wanted to say that, first of all, we thank Germany for organizing this very, very important discussions. And we also thank Germany for maintaining really its support of global health, which really makes a big difference, a good friend really of us, for example, in Africa in time of crisis. And we see, as you continue looking at the areas that will be of priority to you, that the strengthening of local organizations, especially Germany, supporting Africa CDC to have enough capacity to play its role on the continent is one thing that we very much really recommend. The second thing is the Lusaka agenda is critical. It's an excellent initiative and an excellent idea, but there's a lot to learn there. We also recommend that Germany also puts its feet into there to also support the personalization of the Lusaka agenda. And then the final point is the strengthening of the member state capacity. There are areas that have been weaknesses, like financial management within ministries of health has been a challenge, and also the integration of systems to ensure that all the key players work around one single system that can deliver for everyone, and also capture new areas like the NCDs and so on that we've been talking about. Thank you very much.
Thanks very much. Thank you for that. Angela, from a civil society perspective, what criteria would you put over the suggestions that are on the table that civil society organizations would support?
I think there are 3 words or 3 sentences. It needs to be more equitable. It needs to ensure a meaningful participation of civil society. Really meaningful. That means, for example, we are talking about on a series of participation of 20 to 30% and not only 1 or 2 or 3 persons. So, and it needs we really need to work towards a primary healthcare and universal healthcare, including SRH and HIV. Very important. These are the 3 topics at the moment.
Thanks very much. Now, Catharina, if I can ask you for a little closing statement, but also to respond to the questions on innovative financing mechanisms, taxes to raise alternative funding, and perhaps also the criteria that have already come out, then I would be grateful, and I let you do the closing statement. Thank you.
Okay, thank you so much. And, you know, these were really good comments and questions, and I think we could discuss these for a long time. So just perhaps briefly, you know, first of all, and this has not been said, I don't think we're talking about a temporary dip in funding, right? We believe this will be a lasting change, requiring, therefore, lasting adjustment of the global health architecture. And, you know, we do think this new era will be shaped not as much by charity, but much more by mutual strategic interests, and hopefully still anchored in solidarity and equity, as you said. When it comes to mutual strategic interests, you know, I think that's where we actually see country health systems in high, middle, and low income countries approaching each other in the challenges, right? In many countries, we see chronic care is no longer affordable. A big focus shift is needed to prevention, right? We need much more investment on the prevention side, on the primary healthcare side. So, and we all have in common the health security interests and the health security, the need to fight health security threats which know no borders. So I do think there is enough common ground in health to keep and maintain this as a high priority. On the criteria, Tanya, I think this is an excellent question and will not answer it today. We've, with many partners here, started the thinking around this, and yes, country primacy and ownership, I think, is an important one. Equity is an important one. I think if a new system cannot serve vulnerable people and cannot serve fragile countries, we've done something wrong. But I also would say a leading principle has to be pragmatism and start with a coalition of the willing, right? Because otherwise, I think we'll not get there in terms of mergers. You know, I do believe, for example, that the debate about starting to merge boards for PDPs or for big global health players is a pragmatic start, because once you have one governance mechanism, the rest can follow beneath, right? So I think there's some very good pragmatic solutions on the table that allow us to kick off and follow with next steps rapidly. You know, the whole financing debate, the innovation debate is a big one. We as WHO are, of course, very much involved on the debt swap debate. We've made this through our G20 financing, health and financing task force, a major topic, because we think that more needs to be done. So happy that the Global Fund has led ground on this, but it's remained also almost in pilot mode, and we've not seen a lot of debt relief. That's what so far. And we think it's an important part of the solution. The UHC hub that we've now set up together with the World Bank is also looking at this and making this a priority in discussion also with regional players and with country players. So yeah, I would say overall, so much to do, so much to discuss still also on the functions, right? What are the critical functions in health, from innovation to market shaping to procurement, supply chain, where again, a lot can be done to strengthen country leadership, regional leadership in supply mechanisms, etc. And the important point you made about we'll not be able to finance health everywhere if we're not building on innovation, if we're not harnessing digitalization and AI. for all that, we need you guys, we need partners on board. And, you know, Paul, we need Germany on board as a thought leader, as a reformer, but also, and I'll close here, as an integrator, because we cannot answer fragmentation with fragmentation. And that's a big risk I see. At the moment, I see all major donors set up their own dialogues, set up their own discussions, wanting to lead in their own ways this reform. And that is a huge risk, right? At some point, we have to bring these various efforts, these various think tank pieces from the European Commission, from Wellcome Trust, etc., together into one effort and move forward jointly.
Thank you so much. To close off, I wanted to share that something that came up earlier from Angela on the subcommittee on global health. It now appears that the subcommittee on global health will not come to fruition, but that there are a number of different formats on the table to take forward the work that the subcommittee used to do. So follow closely from where you sit of what's happening in this space. But I think we will still have the discussions with Parliament in this space. And otherwise, I would like to thank the speakers, the panelists, very much for giving us some insights onto where we stand in this discussion, to discuss with you what the criteria are for reforming the global health architecture. I think some of these are country ownership, equity, alignment with national health systems, and the call to not answer fragmentation with fragmentation, to avoid that that each entity is going to limp alone. So I will remember that statement very much. Dr. Ngongo, please bear with us for a second to stay online for a photograph. And to all of you, thank you very much for joining this session. Leonie and Katrin have a brief introduction to the next session after the coffee break.
No, now. Yeah. If you don't mind, I even have something to say now. So please wait a moment and maybe we can take the photograph and then, no? Okay, so then it's us first. If you don't mind sitting here while we speak. Okay, because this is important. Because we have a little experiment we want to introduce to you now. And I have to do that before the coffee break, so that's why I have to do it now. We said that we want to keep discussing this topic because the questions you asked show that you really know what we are talking about. The inputs of our panelists really show that you're super deep in the discussion. We have a lot of knowledge here in the room, but it is also a difficult topic. You don't really know where will it head. Sometimes, at least that's how I feel. Sometimes I don't know what to think because how can I talk about an opportunity and if there's women sitting on the ground without help in East Africa, if the HIV epidemic is coming back. But at the same time, we talked about